Welcome to the Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner, and today I have a very interesting program, a topic that we've never touched on before, and that is women in medicine in the military. But before we get started, I want to thank our sponsor, locumstory.com. If you're considering locum tenens, either full-time or on the side, you probably have a question or two, or 20. Fortunately, locumstory.com has the answers you need. It's packed with unbiased information and advice from physicians. Locumstory.com has nothing to sell. It's simply an information resource. You'll find super handy tools that let you see locum tenens trends for your specialty and compare different locums agencies. There's even a quiz to help you decide if locums is right for you. Locumstory.com is the perfect place to start if you want to learn more about locums. That's locumstory.com. And now, without further ado, let's turn to our guest, Erika Kappes. Erika, thanks for joining the program.
Thanks, Dr. Wilner, for having me on. It's great to be here.
Now, I understand at one point in your life you were Major Z.
Major Z.
Major Z. I want you to tell us how that happened, and then later we'll get to what you're doing now. So tell me how you got into the military.
Yeah, so I went to University of Virginia for my undergraduate degree, and at the time I was studying literature as well as some biology, and I thought that possibly I'd want to go to medical school. So once I got out of college, I did some extra courses in biology, chemistry, physics, and decided to apply to medical school at that time. I really, I come from a Marine background. My father is a former Marine and my brother is a former Marine. So I thought, let me join the Army because seems like a good idea, instead of the Navy, I guess, and have them pay for my medical school, and I would be commissioned as an Army officer. So I accepted what's called the Health Professions Scholarship, which is the HPSB scholarship, and you get commissioned as an Army officer or any other branch prior to entering medical school. And then the service pays for your medical school. They pay you a stipend through medical school. And then when you get out, you are promoted to a captain, and then you typically go to residency at a military installation.
Okay, so let's just stop there and recap for a minute. So you graduate college, you think, well, medical school is a good idea. And you've got this pretty influential military, background, right?
Yes.
And dad's a Marine. And say, well, military sounds good. Plus, there are these a really important financial benefit. I mean, these days, medical students are graduating, with $250,000 in debt.
Absolutely.
And you're going to have none. And they're actually going to pay you, right, to go to
Right.
medical school. And this is the part I like the best. You're going to be an officer. Somehow, it seems like cheating. You just
Right.
sign and you're already an officer. How does that work?
Yeah, so I mean, I guess you're already an officer because of the education piece. So I guess they, probably see medical school as a gauntlet that you're running on some level, and so which it
Okay.
is.
Well,
And
which
then
it is, right?
which
Which
it
it
is.
is.
Yeah, so it's an atypical course to the military, but when you get out of medical school, you actually get paid as an Army captain, and I'm only speaking from the point of view of the Army. The Navy and Air Force are similar, but this is very Army specific, just because obviously I was in the Army. And so you get paid as an Army captain through residency, which compared to civilian residence is quite a bit higher.
So what about the Marines? How did you escape the Marines? Didn't Dad say, hey, Marines are for you? Or did he think maybe Marines wasn't the best course for his daughter?
Honestly, it was something much more basic. The Army recruiter called me back faster. So I think that's probably what guided me in that direction. He also put me in touch with other Army physicians, which I really appreciated, other females who were in the Army. And also the Marine physicians they're typically Navy physicians who are embedded with the Marine Corps. So you essentially are still Navy, you just get sort of attached to a Marine unit. And so I decided to go Army and go venture out, be a little different. And so I went to Walter Reed National Military Medical Center in Bethesda. That's where I did my psychiatry residency for 4 years.
So that's a military hospital?
It is a military hospital. It does serve the Navy, Army, and the Air Force just because of the location and how big it is. So it's not the same as if you were at Fort Stewart or Fort Bragg, which is really Army specific. But because of this hospital is near NIH, it was an amazing training experience. I got a great experience there.
Right. Well, Walter Reed, named after Walter Reed, was the guy, who discovered that the mosquito was really the enemy, right? And
Right.
did a lot for malaria and did a lot of research. But so let me ask you a question. Suppose I could go to any residency training program that I want in the country, in U.S., and military, non-military, doesn't matter. I'm really talented. I'm super smart, and I'm really aggressive. Okay, so where would Walter Reed fit in? In other words, am I limited because I'm in the military, or do I actually have access to a great program? How do you think that program stacks up?
So the program, I felt it was amazing. I thought it was great. It was a great program. I can't really say how it stacks up to some of the other big ones like UPenn and some of the biggest psychiatry names, MGH, stuff like that. But I mean, I had a very well-rounded education there. The thing about the military is that the residencies are sort of based on the military need. So there's really only one neurosurgeon that's getting trained a year because the Army doesn't need a ton of neurosurgeons. And so depending on the specialty, some of the branches will do civilian deferments and allow you to do a civilian residency depending on the specialty. That is not typical in the Army. But for example, I've heard the Air Force does that sometimes. I can't speak to those details because that was never an option for me. But I do know that that is a possibility depending on the specialty.
I see. But bottom line, you felt you were in an excellent residency,
Oh, yeah.
uh, even though, or maybe because of, you were enlisted in the military.
Yeah, and the thing is, like, I think there's this thought that, oh, I'm only seeing the military population in residency, and that is not true. I mean, I was at civilian hospitals, I was at St. Elizabeth's in DC rotating, so I saw a wide range of pathology, not just the active duty military population, on the inpatient wards. So I felt like my education was very well rounded.
And what was your residency in?
General psychiatry.
General psychiatry. Okay. So certainly are special needs in the military. It's a
Yes.
kind of a unique, stressful, I mean, there are lots of stressful environments, but the military kind of has its unique take on that, right?
Yes, and I think right now, psychiatry, behavioral health is very much focused on in the military. For a long time, there's been, pretty heavy stigma against anyone seeking behavioral health care, and now that's becoming more normalized and more, encouraged if people are struggling in the military. So I think right now there's a big sort of focus on mental health in the military for a variety of reasons. Suicide rates in the military get very much publicized, and people question, what's going on and that kind of thing. And so, and PTSD, obviously, after the war, that was very much, on the forefront for the Army, especially. How do we, combat PTSD and help these folks? So it's a huge part of military medicine, and psychiatrists are in very short demand, even in the military. So it's a very busy job.
So there's been a lot of evolution. I think, years ago, the military approach to psychiatric problems was, suck it up, right? And
Right.
that was kind of the end of it. But it's very interesting that the symptoms, for me practicing as a neurologist, that the symptoms of traumatic brain injury that we see a lot of, there's a big, I'm sure you'll agree, and if you don't, you can disagree, but if that there's a big overlap with PTSD, right?
Absolutely.
And so
Absolutely.
where does if a bomb blows off, right, and you have a blast injury? In fact, we had a fellow here in Memphis, Dr. Sow, who is a military physician, and
Hmm.
he was at the VA here for years and just transferred to New York. But his research area was blast injury.
Yeah.
That's really a head injury. And the symptoms, headache, difficulty concentrating, anxiety. How do you separate that from the trauma, right? The psychological trauma of, a bomb blowing off right next
Right.
to you and people, body parts flying. So
Yeah.
I think that's really important.
And there's sometimes no way to separate kind of, it's really how can we help take care of these folks for the long haul, because that's really what they need, not just the acute care, but also the long-term management of these symptoms.
Now,
And
when
so
you're in the residency, in a military residency, is there any military stuff going on? I mean, you got to show up at 7 a.m. and salute the flag or run laps
no,
or.
no. I mean, really, you're getting up at that early to go because I mean, obviously, the first intern year is internal medicine mostly, so you're at the ward much much earlier than that, I would say. But we did have to do twice a year physical Army PT tests, and you have to pass the PT test to go continue through the residency. So you can get pushed out of a residency if you're not making height, weight, or passing PT tests. I mean, I think some people forget that you are an Army officer as well, and this is part of the job. It's not just a 9 to 5 punch in, punch out, eat whatever you want kind of thing. You do have to maintain standards. And this, I always tell students when they go into the military, this should not be a surprise to you. I mean, you should go into this eyes wide open that this is part of the job.
What else? What else is part of the job?
So, I mean, you serve two masters. One is the medical side of the house where you have to, deliver patient care. The other side is the unit that you're attached to. So your company commander, all of the administrative military piece. So they want to make sure you're up to date on all of your own medical care, that you've passed your PT test, that you're qualifying on the range. Basically, it's just to make sure you're deployable so that if we had to deploy tomorrow, you would be able to, based on administrative pieces, physical fitness, that kind of thing. So I always say you serve two masters. You have to keep that in mind all the time, that medical is not your only job. Your other job is to stay fit and also be very in tune with what the military needs from you.
Now, most people find being a resident serving one master quite sufficient. Uh,
Yeah.
was it burdensome having to serve two?
In residency, they really try to leave you alone as much as possible. I mean, as long as you're doing your PT tests, making height, weight, making sure your paperwork is in line. They really try to let you focus on your medical stuff. That changes a bit when you get out as an attending in sort of the actual Army, as I call it.
Well, let's talk about that. All right, so you graduated now, you're studying for your boards, and you get a phone call, or I don't know, how do they communicate with
Well,
you?
basically at the end of residency, they say, you're going to get stationed at Fort Stewart, which is where I was stationed. So you're
Which
going
is
to
where?
Savannah.
Where's Fort Stewart?
That's near Savannah, Georgia.
Oh, yeah, so a warm and cozy place, right?
Very cozy, very cozy. Yeah, it could have been worse. I mean, I love Savannah. The bases are never in those cities. They're typically in smaller places.
Yeah, and the swamp. Isn't there a big swamp next to
Swamp.
Savannah? I think, yeah.
Swamp, yes, it is a swamp. It's swampland out there. But it's I mean, it's, you get used to it. I kind of got into Southern living. It's nice. It's a beautiful, beautiful place to live.
Savannah is beautiful, yes.
Gorgeous. But so you end up getting stationed at a base. So I was stationed at Fort Stewart. I was attached to the medical company there. So my job when I initially went to Fort Stewart was to run one of the clinics. I also had to sometimes cover the inpatient wards because there was a shortage of psychiatrists at the time. So there was a lot of different roles I was playing. And halfway through my time there, I switched to being more of a behavioral health consultant to the leadership on the base, as well as running a clinic and still covering the inpatient ward.
Now, whenever a resident graduates from residency or their fellowship, there's a certain amount of uncertainty about your own skills. You're an attending, and so you would expect some trepidation as being within normal limits, I would say. But would you say that you felt well prepared for what they were asking you to do?
I felt prepared. I was nervous, and I also felt, their imposter syndrome is real. So there are times where you're like, oh my gosh, how did I end up here? Should I have this kind of responsibility? But to be truthful, there was still trepidation. But was I prepared from understanding the Army, understanding what was expected of me? I would say yes. I think sometimes in residency, you're shielded from some of the administrative burdens and maybe the volume even of patients. There was a greater volume of patients I was seeing in outpatient, which was sort of shocking to me, I think, but that took a little bit of time to get used to. You don't have all the time to sit and sort of reflect on each case and talk, that kind of thing.
Right. Well, you've transferred from an academic setting. We can make rounds all morning on 3 patients at the university if that's, what presents itself. And then I was in private practice before, so I was kind of shocked, when we sort of look at, oh, we have a busy day, and I'd say there were, 10 patients today, instead of
Right.
30. So that is different, but it sounds like you were well prepared.
I was prepared. I was prepared.
And then, okay, so I don't know, I just heard what sounded like a fire truck or an ambulance. Doesn't sound like you're in the swamp anymore.
No, I'm not.
Where are you now?
So I live in Alexandria, Virginia, so right near outside of DC, and I run my own private practice here. So I got out of the Army a little over a year ago in July, and I switched to. I took a couple months off, and I switched to working for a big telemedicine company for 8 months, as I was trying to figure out where I wanted to move. And I did not like that because there was sort of, as I call it, factory psychiatry, just like, getting through as many patients as possible, not really getting to know anyone. It's not really why I went into medicine. So I basically left that position and opened up my own practice in a way that I wanted to practice medicine.
Okay, great. A few things to talk about there. One, telemedicine. I've written about telemedicine since it was invented. And I think we should probably do a whole program on that because there are real pros and there are real cons. And I think, if you see the headlines, it sounds like, the greatest invention in the world. And in some cases, in fact, the military pioneered telemedicine originally.
Mm-hmm.
All right, but that's a different program.
Sure.
So now you've graduated your residency. You're working as a very busy Army psychiatrist, and they're asking you to do a lot of things, and you're filling those shoes. And how long did you do that?
So I was, after residency, you typically owe 4 years back, as long as your residency was 4 years or less. So for internal medicine physicians, they owe 4 years back. Pediatricians, 4 years. If you go into general surgery, which is typically 5 years, you owe 5 years back. So otherwise, everyone owes 4 years back. So I did my 4 years after residency between Fort Stewart and Hunter Army Airfield, which is just basically the aviation side of the house. And I stayed at Fort Stewart for the 4 years and did a lot of work there, and then decided it was time to get out.
Now, what about medical school? You don't owe them anything for that?
I don't owe them anything. Oh, so yeah. So the 4 years after residency is for medical school.
What about for the residency?
That's considered part of the active duty.
Oh, so that's active duty. So really, so you're getting 8 years of Army support, and
That's
you
correct.
owe only 4.
That's correct.
And then
Yeah.
after the 4, how many on the
Reserves.
Well, what does that count? How many have you actually put in?
So 8 years active duty, and you can choose to stay on with the reserves if you want to continue your time. I decided not to do that, but some people do decide to continue on with reserves to keep adding to their time, maybe towards retirement. And then you get out with no student loan debt, as well as the GI Bill that some people can use to go back to fellowship if they want. Sometimes you can transfer it to your children, but I think you have to be in at least over 10 years for that. I could be wrong, but that's my understanding. And then as well as the VA home loan, which is actually really helpful if you want to buy a house, zero down, and this, it can be really helpful. And so there are, incentives, even, and great benefits even after you get out of the military.
Do you qualify for any monetary pension after 8 years?
No, I don't.
No. Okay. So that's
you have to do 20 years. So it's,
you have to do 20 before they're going to pay you not to work.
12,
All right.
12 more is quite a chunk of time. So.
All right. Was there a single, I mean, it sounded like the Army treated you well and you enjoyed it and you worked. Can you point to what, you're a psychiatrist, so I'm sure you've thought about this. What pivoted you to private practice?
So the military system is totally, and this could be a whole show on itself, but it's a totally different system, obviously, than civilian medicine. So my population now they typically are paying for my services. They're very motivated. There's, a lot of investment in care. In the military, whether we like it or not, there is a financial incentive on some level to, at times, seek medical or psychiatric care. So this may be the elephant in the room, but I like to talk about this, is that, the more that people seek care, like a lot of times they start seeking care for disability payments. So they want it on their record to then, basically qualify for disability. On a shorter term, while in the military, if people seek psychiatric or certain medical care prior to deployments, they may become non-deployable. So there's secondary gain that sort of streaks through there. And not everyone is seeking things for secondary gain, but that is, as a psychiatrist, that was a lot of, at times, what I was trying to do, decipher what was, sort of incentivized by different things versus true pathology. And that really makes one jaded after a while, I would say.
That's interesting.
I would say that by the time I was out of the Army, I had what I term, and this may be like, I don't know if this is a term, but I made it up, is empathy erosion. I felt a little bit crispy, so I had to take some time off. And I would say that my colleagues all typically felt the same and still feel the same. Whenever you tie financial incentive or incentive in general to subjective symptoms, there's a lot of people that can start becoming chronic patients.
Right. It sort of opens up the whole world of things that can happen. Well, in my practice, for example, we see patients from jail. The jail patients come to us. Now, there is a difference between jail and the military, but it is a confined kind of, and, getting out of jail and being admitted to the hospital is usually a bonus, right? If given the choice, do you want to be in jail? Do you want to be in a hospital bed? A lot would choose the hospital bed.
Right.
And so it's very, very hard when patients have a subjective complaint, severe headache, or what appears to be, I'm an epileptologist, so what appears to be an epileptic seizure, there's this whole pseudo seizure thing.
Right.
When it's a jail patient, you always roll your eyes a little bit. And on the other hand, jail patients also happen to have an increased risk of epilepsy because they're, had a rough life. So it makes it much more challenging.
It's very challenging. And I think that and then there's a whole nother subset of patients who are very high performers in the military who never seek care because they want nothing on their record and they don't want to be taken from duty or anything like that. So there's two extremes that I would typically see in clinic or in my practice. And both are frustrating. And it's a frustrating paradigm for a physician who wants to help people get better and is throwing sort of evidence-based treatment at folks. And, I've done a few talks on how the current disability system is actually harmful for long-term health. And it's sort of a passion of mine to talk about that, whether it's popular or not. But there is underneath some of the care sometimes secondary gain. And so I think that was very difficult for me to handle after a while.
Right. Well, of course, that's not unique to the military. Even our
Sure.
disability system in the real world and in the VA. In fact, there's a book written by a veteran. He's a decorated veteran.
Dr. Gabe?
I'm trying to remember. In fact, I was thinking of interviewing him on this program, where he felt that the VA really did a disservice to the veterans who were discharged by having them tally up all the reasons why they couldn't work as opposed to pushing them to all the reasons they could.
Sure. And then, a lot of these folks end up getting paid to stay ill. And if they report subjective symptoms that are improving, they no longer get paid. And so that actually causes, they're acting like rational actors, as I say. People will, report ongoing illness to get paid. That would be rational. So the system, in my opinion, needs a lot of work, and it's actually not promoting growth. But that may be, and I've given talks about this at Fort Stewart as well as at the American Psychiatric Association. I used to work with a forensic guy to talk about malingering, and especially in the military system. But that is what I would say was probably my impetus to get out. I think you get to a point where you're like, I need to move on to something else.
Very interesting. Well, I hope the Joint Chiefs are watching the program, and they've got their hands full with that particular.
Yes.
They got to change the rules.
Yeah.
All right, now we're actually running out of time, and what I really want to talk about now is the advice you would give to a young woman. She's 22. She's really smart. She can do anything. She's thinking about going to medical school. We talked about the financial incentive. Mm-hmm. So that's pretty clear. If you don't want to graduate with hundreds of thousands of student loans, that's clear. But suppose, let's take that out of the equation. I always like to take money out of the equation. And it's like, okay, you can do whatever you want. What would be the reasons to join the military?
Well, I think some people have a burning desire to, serve in the military. And I think that is really noble and admirable. And if that's the case, it's a perfect way to do it if you want to be a physician as well. And so some people really enjoy that aspect of it. Camaraderie is definitely a big part of it. I miss a lot of my colleagues that I used to be a part of in the military. So these are all wonderful aspects of the military, especially as a physician in the military.
Now, what about as a woman? Are there female restrooms? I mean, there was a day when being a woman in the military wasn't so straightforward.
Sure. I mean, there are times I think things have improved. At times it can be difficult. It is mostly, I would say, majority. It's still men in the military. But for me, and what I tell other women is, hold yourself to a high standard. Make sure you're keeping up with fitness. Make sure you look really good in uniform. Make sure that you are keeping yourself lean and healthy. And so all of these things, the way you carry yourself and the way you present yourself, whether it be in meetings or in a room full of, male colonels, as I often had to speak, the way you present yourself is really going to carry the day. And so I think it's a challenge, but it's, I had a good time, basically doing that and sort of and I sort of built on these skills, that I didn't know I had. So.
Well, I think women in corporate America would probably say the same thing, right?
Right.
It's male dominated, and you show up looking like a captain, right?
Yeah.
Yeah.
I always did I was always one of the top of my physical fitness tests. I would, I sort of took pride in that. I always kept myself looking really lean and uniform. And so these are all things that people took me seriously. And I spoke with authority, whether sometimes, faking it till you make it, but still you have to, sort of speak with confidence, and these, you develop this over time.
Any female specific negatives for this young woman who wants a military career?
I mean, I think you have to be prepared that, sometimes if, for me at times as a small female, I often felt like I wasn't being taken seriously, even though I might be the most educated person in the room. That didn't bother me for too long. I would typically move on and just continue to, do what I had to do, but that can be difficult at times.
Well, I'm a tall male, and I've had that experience as well. So,
Yeah, I mean, so you
that
get it.
happens. All right. So, is there anything else you'd like to add before we wrap up?
No, I think what I would like to say is that if someone is considering military for medical school, it would be good to talk to multiple providers in different services, which is what I did with the Army, but really to get multiple points of view. I think that's really important, to go in eyes wide open. And it's not to sort of romanticize it, as well as to understand that the military part is a huge part of being a military physician.
All right. Well, before we close, brief ad copy here. Finally, many thanks to the Art of Medicine's wonderful sponsor, locumstory.com. If you're interested in learning more about locum tenens or considering a new full-time position, please go to locumstory.com. Dr. Erika Kappes, this has been great, enlightening for me. And now, if someone wants to contact you ask questions, because I would endorse what you said, and it applies to locum tenens too. It's like, oh, there's some new thing. Should I do it or not? It's like, talk to somebody who did it or who's doing it, and and they'll give you the answer, right? Talk to a few people, because people contact me all the time, and I tell them what's positive and what's negative, and there's nothing like talking to somebody who's been there. And that's why we're talking to you today, because you've been there. And I think it's great. You've experienced these two worlds. You've got, 12 years of military background, and you know how to salute and present yourself and command. And now you're in charge of your own practice.
Yes.
I think that's really terrific. So how do we get in touch with you?
So, I mean, email is good. So it's Dr. Kappes, so DrKappes at district-wellness.com. So Dr. Kappes at district-wellness.com.
Nice. Well, Dr. Erika Kappes, thank you so much for being on The Art of Medicine.
Thank you so much for having me. It was wonderful to talk to you today.
This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on the art of medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com